It's different now, it's moving. And I can't face your smile. It's like I never feel you say that. Reaching out for mine. See the way it looks like. All the stage you're through. If I don't believe in love, nothing is good for me. Believe in love, nothing is good for me. If I don't believe in love, nothing is good for me. Nothing is good for me. Nothing is real for me.
Hi, Doc.
Hi, good evening.
Good evening, Doc. Welcome.
Yeah, thank you. So, I guess. Okay.
Yeah, 4-5. Let's start. Yeah.
So, the HOD we have a platform. So the HOD put some information there. He said we have a meeting at the on campus at 10 a.m. tomorrow.
Okay.
So hopefully we might get to have more discussions and then we can fine tune whatever arrangements there are. And then I also listened to the Ministry of Education's information press briefing today.
Okay.
And it was also quite informative. So most likely school would start soon, but it all depends on the pilot, how things go. And as far as examinations are concerned, exams will be held. So what I see happening is that we'll still probably continue with the Zoom lectures. And then maybe a timetable will come out for exams. And when it's time for exams, you just come and have the exams done. But there will be no actual lectures held. That's what I see happening.
No, but you know, sometimes when I think about it, I'm like, it's a bit unfair because we didn't have a normal class lecture, but we are going to have a normal exam.
No, but the fact is that you still have lectures. I mean, luckily for you, you're still having lectures. So you need the lecture stand in front of the class before you understand. This is still okay.
Most of the lectures
don't come online. Apart from you and microbiology, most of them don't come.
Pharmacology has never stepped in a class before. I mean, yes, online one. Never, no one.
So what about Dr. Insafu? Does he teach you?
Dr. Insafu doesn't teach us.
No, he teaches some of us, those who joined us in level 200.
Yes,
yeah,
he comes.
Told me that he's been doing the Zoom lectures.
Yes, he does. He does.
Yeah.
Okay, so let's start. We'll talk more when we finish. So we are looking at nutritional diseases today, and this will include a general overview of the nutritional status. We'll look at kwashiorkor, we'll look at marasmus, we'll look at bulimia and anorexia nervosa, and then obesity as well. Then we'll look at healthy eating and diet, and contribution of diet to cancer. And we know that an appropriate diet should have energy, it should have amino acids, it should have vitamins, minerals. If the diet doesn't contain adequate amounts of this, then patients will end up with malnutrition. Now, malnutrition just means that one or all of the components are missing from the diet. And we can have primary malnutrition and secondary malnutrition. Primary malnutrition means the diet is inadequate. Secondary malnutrition means that the diet is adequate, but there is something wrong with the body that is not allowing the body to absorb or utilize the nutrients that are taken in. So this can occur from nutrient malabsorption from the GIT, or impaired nutrient utilization or storage, or excess nutrient losses. So either the nutrients are lost in the stool or in the urine, or there's a metabolic condition of the body that increases the need for nutrients. Now, the common causes of dietary insufficiency can be ignorance. So basically, the person doesn't know what to eat, or poverty. It can also be from chronic alcoholism, and for alcoholism, it's mostly the B vitamins which are lacking, as well as vitamin A. So for alcoholics, a combination of these things can cause the dietary insufficiency. So either they don't eat well because they are always intoxicated, or the alcohol causes atrophy of the villi in the gastrointestinal tract, so they are not able to absorb the nutrients. Or the nutrients can be absorbed, but their storage is problematic because of probably liver damage from the alcohol intake. Or there's an increased rate of loss from that. Then acute and chronic illnesses can also cause dietary insufficiency. So if you have an illness, usually the illness takes a toll on the body's metabolism, and so you might need more to keep up and there's excess production of antibodies to fight off infection, and all these things need energy. And so acute and chronic illnesses can cause dietary insufficiency because there's accelerated basal metabolic rate. Sometimes too, it can be self-imposed. So people with nutritional or food diseases like anorexia nervosa, who have an unreasonable body image such that they don't eat, or they eat only certain things. Or the patient has malabsorption syndrome such that maybe when they take in fat, the body cannot absorb fat from the GIT. Or they might have a genetic deficiency which causes dietary insufficiency, or certain drugs. So for example, there are certain medications that block fat absorption in the GIT. An example is Orlistat. So let's look at protein energy malnutrition. This can sometimes be fatal, and it occurs commonly in third world countries, and mostly children are affected, and it causes a whole lot of problems in the whole body of the child. Now, for you to understand what problems occur, you need to understand the protein compartment in the body. We have the somatic protein compartment, which is represented by skeletal muscles, and then you have the visceral protein compartment, which is represented by protein stores. Now, these two compartments are regulated differently. The somatic compartment is the skeletal muscles. That one is mostly affected when you have marasmus. But the visceral compartment, which is the protein stores, is mostly affected in a disease like kwashiorkor. So that gives rise to the various clinical states that you find, and we'll see them as we go along. So how would you assess the nutritional status of a patient and decide whether the patient is malnourished or not? You look at the weight of the patient and compare it to the height of the patient for a given standard. Then you can also look at the fat stores, the muscle mass, and then serum proteins. For the serum proteins, you take blood and measure. So you can measure the serum albumin content, for example, or the total protein content in the blood. Now, with the fat stores, you can use calipers to pinch off the skin and then measure the amount of subcutaneous fat. Or even in any patient, when you pinch off the skin, if there's fat, you pick quite a sizable amount of skin in your hands. But if there's no fat and you pick the skin, you realize that the skin is very thin. Okay. Now, if you check these things and you realize that the weight of the child falls below 80% of what is expected, then you say that this child is malnourished. If the weight falls to 60% of the normal, then this child has marasmus. Okay. If you look at marasmus, sorry, let's go to the previous slide. Yes. So a child with marasmus, they lose a lot of the somatic protein component, that's a skeletal muscle. So you have a lot of loss of muscle. And this is because they are growing quickly and they need the protein to for metabolism. And so the muscle mass is lost. And usually this is an adaptational response that helps them to use the protein as a source of energy. So for children with marasmus, they lose a lot of the somatic component of protein, which is the muscle. But however, the visceral component is hardly depleted or very marginal. So this means that things like albumin, which is produced by the liver, will be spared. So if you check the albumin level, it might be normal or slightly reduced. Meanwhile, they would have lost a lot of protein. Okay. So these patients, their extremities look emaciated, like they are skinny. And because of their general skinny nature, the head appears too big for their body. Then then you also find that they have anemia and C and so on, and this can lead to concurrent infections. So when we look at kwashiorkor, I don't know if you understand Ga, but it's a Ga word, and it takes its origins from the colonial era. It was actually coined by a white pediatrician, Cicely Williams. She worked at Princess Marie Louis Hospital. And so, as you know, Princess Marie Louis Hospital is actually a malnutrition hospital. So what happens is that, let me just give a little history. I'm sure our time will be up to date too. So when you have a baby, let's say the baby grows to become a toddler, if the interval between that toddler and the next baby is very short, what will happen is that maybe that toddler is like a year and a half or 9 months, or let's say 10 months, and then you get pregnant with the next one. So by the time that toddler is like a year and a half, there's a little baby in the house who is competing for attention and resources and all that. What happens is that attention gets shifted from that toddler. And that is the time that that baby is very vulnerable to malnutrition. So what happens is the baby, the growth of the toddler becomes stunted, and then it becomes halted, and then the baby sort of grows to catch up with the toddler. So then when you see the two of them together, they look like twins, and so you call them kwashi kekoko. That's like kwashi and koko, like twin children, okay? But actually they are not twins. It is a sibling and then the younger sibling. So with the saying of kwashi kekoko, then it became kwashiorkor. That is the history behind the name. And usually what happens is in kwashiorkor, there's a lot of protein deprivation. And the protein deprivation is usually greater than the energy deprivation. And it's the most common form of protein energy malnutrition in African children. And usually, yes, there are children who are whose siblings are born too early, and so they are usually deprived of protein and fed on an exclusively kwashiorkor, there's a lot of loss of protein from the visceral protein compartments. Unlike marasmus, where the loss is from the somatic protein compartment, which is the muscles, in kwashiorkor, the protein is lost from the visceral protein compartment, and we will subsequently understand the effect of this on the general metabolism. This protein problem with protein malnutrition can also occur in children who have chronic protein loss. So, for example, those who are losing protein in their urine, or those who are losing protein in their stool, or after severe burns where the patient loses protein in the serum from the skin, from the oozing skin. And so because a protein is lost from the visceral compartment, worse than marasmus. And because of this loss of protein from the visceral compartment, which is where the organs are, like the liver, for example, there's reduced synthesis of albumin from the liver. And so this leads to hypoalbuminemia. And if you remember when we talked about edema, hypoalbuminemia is one of the causes of edema. And so these children typically will have, they'll look edematous, they'll be swollen up. And when you check their weight is
What's happening?
Oh.
I don't know.
So no, I think it's her network. Doctor's network is, I think, frozen.
Oh, Kwashi and Koko.
Kwashi and Koko, dear Kwashi and Koko.
There we have a true story.
Hey, original.
Where's the Koko?
Rabs, how are you?
I'm fine. Yourself?
Oh, I'm also good. Today they have been able to join.
Oh yeah, that's great.
Why? Appassionata.
Kula, enka topic with the enka odie pa o. Onso so.
I have to reshare the slide.
Yes, Doc, you have to reshare.
Okay. Okay, so we're talking about kwashiorkor. So because of the edema and the swelling, the skin sort of stretches. And so the skin has this hyperpigmented lesion. So it gives the appearance of a flaky paint appearance. You see, when you have a wall with the paint flaking off or some of the paint peeling off, you have areas where the paint is still intact, and then you have lighter areas where the paint has peeled off. And that is the appearance of the skin in patients with kwashiorkor. Then, let me put it on slideshow. Okay. So overall, when you look at these patients, they have some changes in their hair. There's loss of the color of the hair, so the hair looks brownish. And then you also have this flag sign. The flag sign is alternating bands of pale and dark hair. So generally the hair looks black, looks brownish, but when you take a strand, you see that there will be alternate dark and brown shades. So it looks like a flag. So we call it a flag sign. Then the hair becomes very straight, as if the hair is permed. And then it has a very fine texture, and it loses its attachment to the scalp. So it is easily, we say it is easily pluckable. So whenever you see a child with malnutrition, you have to look at their hair and see if you see any of these changes as well. Then other features that would differentiate kwashiorkor from marasmus are the fact that the liver is enlarged. Because of the reduced synthesis of the proteins, the liver tends to tends to enlarge to overcompensate from this reduced synthesis. Then they also have a tendency to develop apathy. So patients with kwashiorkor, they look very apathetic, like they are not interested in their environment, they won't play with toys, they won't smile, they are just there. Compared to patients who have marasmus. Marasmic patients, they are eager, and the other difference is that patients with kwashiorkor have a low appetite, but marasmic patients are very eager and they eat with a lot of appetite. Here too, you have a defect in vitamins and then immunity. So because of their decreased immunity, they are prone to secondary infection. The decreased immunity is because of the little protein that they have. You know, the immunoglobulins which help us fight against infections are all proteins. So if you have a low level of protein, it means all those things will be affected and you'll be immunocompromised and prone to infection. So this is a clinical picture of a patient with kwashiorkor. Note the generalized edema, which involves the lower limbs, the legs, the arms. The abdomen looks distended, and the eyelids are shut. And you can visibly see the shiny eyelids from the massive accumulation of fluid. So secondary protein energy malnutrition can occur in any patient who is chronically ill. So for example, patients with cancer who experience wasting. It is because they have an increased metabolic rate because of the cancer, which produces cytokines which cause the breakdown of proteins. So morphologically, you'd realize that the patient has growth failure. So the patient is shorter than expected for age and smaller than expected for age and not as heavy. Then there's also peripheral edema. Please excuse me. Please.
Who is wearing a
So yes. So in the brain, for example, there's a reduced number of neurons. And then there's decreased myelination of the white matter. So this is why we say that when there's malnutrition in the first 2 years of life, it can slow brain growth and lead to cognitive impairment later on in life. Then you can also have changes in the thymic gland, where the thymus becomes atrophied with atrophy of the lymphoid glands. So the thymus is responsible for the production of T lymphocytes. Then you can also have intercurrent infections and then deficiency of iodine, which can lead to goiter. Okay, so that's kwashiorkor. So we'll move on to anorexia nervosa and bulimia. So those things occur in children. In adults, you can have anorexia nervosa, which is a self-induced starvation, basically, which leads to marked weight loss. But in bulimia, there's binge eating, and then the patient feels guilty and vomits later on. So all these two are body image problems, which leads to eating disorders. So generally, if you take anorexia nervosa, you have all the things that we talked about in protein energy malnutrition, the wasting, the decreased protein levels and all that. But additionally, they also have endocrine problems. So some of the endocrine problems they can have are amenorrhea. And this is because there's decreased synthesis of gonadotropin releasing hormone from their hypothalamus. So this gonadotropin releasing hormone is supposed to stimulate the anterior pituitary to produce follicle stimulating hormone FSH and luteinizing hormone LH. So when the gonadotropin releasing hormone the level is decreased, it will affect the levels of FSH and LH, and therefore you have little or no levels of estrogen and progesterone, and so there will be amenorrhea. That means that patients will not have their menses. They also have decreased thyroid
please,
hormone.
can you go over this explanation again?
Okay, so we know that the menstrual cycle is controlled by estrogen and progesterone. And patients with anorexia nervosa, they have endocrine abnormalities. And one of the key endocrine abnormalities they have are decreased levels of gonadotropin releasing hormone. This hormone is released from the hypothalamus and is responsible for stimulating the anterior pituitary to produce luteinizing hormone and follicle stimulating hormone, which will subsequently induce the ovaries to produce estrogen and progesterone. So without the gonadotropic releasing hormone, all these things will not occur, and the patients will have amenorrhea, meaning there will be no menses. Okay, so subsequently, by extension, it means that there will be fertility problems as well.
Okay.
Then the other hormonal problem they can have are thyroid hormone, decreased thyroid hormone release. And you know that the thyroid hormone is responsible for increasing the basal metabolic rate, increasing the heart rate, helping with production of heat in the body and all that. So when you have hypothyroidism as a consequence, the patient will have cold intolerance, meaning that when they enter into a place and the place is cold, they cannot stand it at all. Then they have very slow heart rate, bradycardia. They have constipation, and then they have changes in their hair and their skin. So the changes in the skin becomes dry and scaly, and it can become yellowish. The hair becomes very fine, like lanugo hair, which you typically see in preterm babies, or like hemmed hair, that kind of very fine, thin hair. Then they also have decreased bone density because of the low estrogen level. We know that estrogen helps with increasing bone density. And that is why when women become menopausal, postmenopausal women usually have osteoporosis, like their bones become brittle and weak. Because when they are postmenopausal, the amount of estrogen is virtually zero, it's very little. And so the bone density will decrease. So these anorexics, they sort of start having characteristics like they are menopausal because of the decreased estrogen levels. So some of the complications they can have are anemia, lymphopenia, that is low levels of lymphocytes, which help with infection prevention or fighting of infection. Then low levels of albumin. But a major thing that occurs is that they have electrolyte imbalance, and very commonly they have hypokalemia. And so this can lead to sudden death from arrhythmia, that is irregular heartbeats. So we move to bulimia. So in bulimia, usually they are not that skinny. They are not that skinny because in bulimia, what happens is that there's binge eating. So they eat and eat and eat, they overeat, and then they induce vomiting. So because they overeat, definitely they can't vomit everything. So definitely some would retain. So they are not as skinny as a bulimic. And they don't have a lot of hormonal irregularities, also because their weight is not that bad. So amenorrhea occurs, but it just occurs in about 50% of the bulimic patients. So, but the commonest problems that they have is problems associated with the induced vomiting. So they can have electrolyte imbalance from the induced vomiting because when they vomit, they bring out gastric acid, which contains potassium and contains chlorine. So they usually have hypokalemia, and that can also predispose them to arrhythmias. Then because of the vomiting, they can aspirate the vomitus into their respiratory system and have pulmonary aspiration. So they can end up with aspiration pneumonia. Then also, because of the induced vomiting and the several times they vomit, they can have rupture of the esophagus and the cardia of the stomach from the repeated vomiting. They do this several times in a day. Okay, so we move to obesity. And we all know what obesity is. Obesity is increased body weight. So it's the opposite of marasmus. And usually, technically, we define it as a calculation using the body mass index or checking the skin fold thickness or the waist to hip ratio. The commonest one we use is the body mass index. So ideal BMI should be between 18 and 25. That is normal. So if you have the weight of the patient divided by the height in meters squared. So the ratio that you get, if you get a figure between 18 and 25, then the person is normal. If the person has a BMI between 25 and 30, the person is overweight. Between 30 and 40, they are obese. And then above 40, they are morbidly obese. This has several risks that are associated with it. Now, we know too that genetic influences are important in weight control, but then genetics is not the only thing at play here. So you can't eat anything you like and blame it on your genes. That's, oh, it's in my blood. My ancestors are fat, so I can't do anything about it. There's always an interplay between the environment and the genes. So regardless of the genes, if the patient doesn't overeat, the patient will not become obese. So maybe the person will be a bit heavy, on the heavy side, but not obese. Obesity means BMI between 30 and 40. So that's quite a lot. There are lots of risks associated with obesity. So diabetes, hypertension, high triglyceride level, high cholesterol level, coronary artery disease. And there are some conditions that you would find in obese patients. So an example is gallstones. Gallstones are 6 times more common in the obese than in the skinny patients. This is because there's an increase in the amount of cholesterol, and gallstones are from cholesterol synthesis. So when you have excess cholesterol, the rest of it is secreted as bile. And when the bile becomes a lot, it coagulates and then becomes stones. So that is what happens. Then patients who are obese also have a problem with their respiratory system because of the excessive fat. They have what we call hypoventilation syndrome. And this is also known as the Pickwickian syndrome. I don't know if you've read Charles Dickens' story. There's this Charles Dickens Pickwick Papers. And there was a fat boy in that story who was always asleep and asleep mostly during the day. And this is a peculiar characteristic of people who are obese. You'd realize that they have this apnea. They have moments where they stop breathing and then they start breathing again. And so they don't sleep well. And so because of the poor sleep at night, they end up with daytime sleepiness. Then obese people also have degenerative joint diseases because of the excess weight of the adipose tissue on the joints. And this is known as osteoarthritis. So this typically occurs the older you get. Okay. There's also an association between obesity and cancer. Obese women are at increased risk of developing endometrial and ovarian cancer because obesity raises the levels of estrogen. The same way that patients who have anorexia have low levels of estrogen, obesity is associated with increased levels of estrogen. So things which are associated with increased levels of estrogen, like endometrial cancer, ovarian cancer, breast cancer, are on the ascendancy in obese women. Okay, so the last thing we'll look at is the diet and systemic disease. We know that the diet is made up of key nutrients which help to nourish and enrich the body. And we also know that the diet is associated with certain diseases. So, for example, obesity mainly, obesity is mainly associated with a lot of oh goodness, Dabi, Akosia. No, don't put on the TV, please. Akos, talk about remote. How more remotes on it? I hope the TV is not disturbing you.
Oh, it's fine.
No,
All right,
dog.
then we'll leave it alone. Akosia, it's okay if I sit down and watch the TV. So we know that high cholesterol is associated with obesity, but we know that there are certain components of the diet which help to reduce the cholesterol level. For example, if you take more of vegetable oils, the oils which contain corn oil, sunflower oil, olive oil, they are good sources of lipid lowering oils. Then fish oils, especially the ones which have omega-3 and omega-6, they are also good in helping to lower cholesterol level. And this helps to prevent or decrease the risk of coronary artery disease. Then hypertension, for example, is also helped by restricting your sodium intake. So just by reducing your salt intake, you either reduce your risk of hypertension, or if you're already hypertensive, you lower that. Then dietary fiber also helps to decrease the amount of cholesterol in the that the body takes in, because the dietary fiber absorbs the cholesterol in the GIT. And then it also helps to prevent constipation, and by that it helps to prevent a disease called diverticulosis of the colon. Then we also know that garlic helps to protect against heart disease. There are certain, so these are the helpful diets. Then on the other side too, there are diets which can trigger, or there are diets which are implicated in the causation of cancer. And there are three main etiologies of this. Either the diet contains carcinogens, things which are known to cause cancer, or the diet contains things that can be synthesized endogenously in the body into carcinogens, or the diet doesn't have protective factors which will protect the body against these cancers. So let's look at some of these examples. So a diet containing aflatoxin. Aflatoxin is a fungus which grows in moist grains, and it can be carcinogenic. Then also food that contains additives, artificial sweeteners, pesticides. They can also be carcinogenic or cancer causing. Some foods which contain artificial sweetness can also cause cancer, example, bladder cancer. Then you can also have a situation whereby when the food is taken in, it is converted into a carcinogen inside the body. An example is nitrosamines and nitrosamides, which are found in smoked fish and causes gastric cancer. Then we also have okay, this is all the endogenous carcinogens. Okay. Then we also have high fat intake, especially animal fat, which which produces a lot of cholesterol